name is Laura Elizabeth Patak, and I'm a PhD student in social welfare here at UC Berkeley, and I'm grateful and excited to be talking to you all today. So I'm going to be presenting on my research that is focused on centering the health data, privacy, and security perspectives of safety net patients. So in partnership with UCSF, my research group here at Berkeley Social Welfare was in the last stage of developing an adaptive text messaging app to encourage physical activity among low-income minority patients. These patients are recruited from an urban safety net healthcare system here in the Bay Area. And we use the term safety net patients to encompass a group of patients who are low income, tend to be underinsured or uninsured, and are usually Medicaid or Medicare recipients, and are disproportionately racial and ethnic minorities. As we were wrapping up testing of the app, questions surrounding security and privacy implications of this sensitive patient data emerged within the research team because we were discussing our informed consent protocol. We were asking patients to reveal private sensitive information to retrieve aspects of the app personalization and to improve the machine learning algorithm, to inform the algorithm. Among those were step tracking data and location data. So although research participants control who can access their personal health information through consent in theory, and the study protocol had been approved by IRB, when we were discussing our process for ensuring a proper informed consent process, somehow some of us assumed patients did not care about the privacy implications of collecting their health and location data, and that most patients will consent. And underlying this assumption is another concern and assumption really that low-income patients' limited technological literacy hinders their understanding of the actual risk and benefits of mobile technology. In wanting to question these assumptions, I brought up these questions of, do we really know that? Have we asked patients directly what they think and what they know? And so I then looked into the literature and found virtually no data on security and privacy standards within the research community for mHealth interventions targeted to vulnerable populations, which is unsurprising and sad given the underrepresentation of low-income racial and ethnic minority groups in mental health and digital health research. And so this led me to wanting to talk about bringing equity to cybersecurity research in healthcare. This is a framework that I'm using to explain how motivated and directed this study. These are some of the framing questions that I brought up and that really helped to shape the scope and the direction of the study. Who are our patients? How can we center their perspectives on these topics? How can we reframe our orientation that tends to be deficit-oriented and prescriptive as researchers to one that acknowledges the strengths, knowledge, and and resiliency factors of patients? And how can we take a participatory approach to designing cybersecurity solutions that are responsive to their needs? And so to be more concrete about the study, really quickly, the objective was to describe the knowledge and attitudes toward the privacy and security of health and personal data of safety net patients, and to get some information that on their opinions and understandings of the risk and benefits and the decision-making processes that they use to when using digital health interventions and electronic health records. We specifically asked patients about location tracking by smartphone apps, about their opinions on existing privacy and security protections, like privacy policies, passwords, and bio identification processes, and then broader perceptions on health data ownership and sharing. This was a qualitative study with individual semi-structured interviews of 20 patients, 5 of whom were Spanish speakers. And we had completed data analysis following thematic coding process of the interview data, following these 7 themes that I'm oversimplifying the process, of course, because we did a code book and we did multiple iterations, multiple versions of the code book among the team members. We followed a theoretical approach, but this is just an oversimplification. And these are some of the main findings. We have not published, but we're in the process of writing a manuscript. And the findings are that privacy security concerns, as confirmed in the literature, are very contextual, and that some of the most important aspects or factors that influence current perceptions of security and privacy concerns are previous experiences with negative experiences with security breaches and the like. Perhaps more localized to the context of this study is that trust in the medical community is a critical factor. Surprisingly, location tracking is a major concern for many patients. There's a huge influence on human relations and social processes in privacy and security decision making. And then importantly, privacy and security policies and practices are highly onerous for patients. In fact, they often talked about how passwords and dual identification processes hinder their confidence and their willingness to engage with technology in healthcare. And lastly, but not least, the meaning of digital literacy is not just about technical knowledge, but there's a huge role in cultural and historical context that plays a role in the digital literacy of this patient population. And lastly, the implications of this research are many, but some of the most important ones is that marginalized communities do have strong opinions about cybersecurity. After all, they're current or very interested users of digital health products. So it's very important to expand who gets to participate in the design of cybersecurity solutions. It's important to think about engaging with these populations, not in us designing around them, but designing with them, or not designing down on them, but designing around them and with them. So in doing that, we hope to center and respond to the opinions and needs for improved cybersecurity practices and policies, which can helpfully contribute to the integration of technology in clinical settings and ideally help ameliorate some of the health disparities that we see. And lastly, this research can help to add more nuance on the environmental and social aspects and processes that needs to be right now are lacking from mainstream privacy theories, which tend to focus on cognitive decision-making processes, so more on the personal level. Okay, that's all I have for today. I look forward to your feedback and comments and questions. And again, thank you for joining me today. This is a team at Berkeley and at UCSF. Thank you.